Testing. All right, if we could ask you to come take your seats, it'd be great. Please come. Plenty of seats in the front. Well, thank you everyone for coming today. I'm very excited about the conversation that we're about to have. First off, my name is Dan Riedel. I'm the CEO of New Context. We're one of the sponsors for this event. And at New Context, we have the vision of keeping the connected world safe. And so this is an event that is very dear to our heart to a certain extent. I'd also like to give a shout out to Rain Capital for sponsoring this as well. Thank you very much. And Javelin, who is not here, actually don't know where Sean is. And Parallax, and also a special thank you for Holly for setting this event up. Holly's sitting back here. She did a lot of hard work making sure everything is in place and herding a lot of cats. And then Jod Adams is running the live feed and eventually putting the camera on me for those people who are watching. That was, never mind. Today we get to hear from Josh Corman and Jacki Monson, sorry about that. And Seth Rosenblatt will be moderating. And just a couple of words before we start. We're coming from a world where we had a very deterministic environment when it came to medical or some things we work on, utility space. And we're moving to a very non-deterministic environment, meaning that a thing operated in a given way no matter what, and now we have a situation where a thing may operate in a given way depending on the operating system, the software, and the engineers who built it. And so we believe that we need to take a long look at how we build software, how we build systems, how we protect data, and understand the architectures that put that together. And so we believe that security is not this thing that you do. We think the security is part of the architecture, compliance is a part of the architecture, and this is how we're actually going to build stronger things. It's a shared responsibility we all have to pull together on, and I think we are getting more and more traction on that, but I think that we need to have more dialogues about the one we have now and continue to spread that word that it's all of our responsibility. So with that, please, the panelists and our host, Seth, come on up. And I will maybe kindly give Seth the mic so he can talk.
Yes, that's helpful. All right. So once again, I just want to thank Jacki and Josh for joining us this evening. The idea for doing this event actually started over a year ago. Josh and I were talking about medical device security, and he told a story to me that struck me as being obviously not just a personal anecdote, but really important in helping understand the threats that medical security faces right now and how difficult they are to communicate them to a wider audience. And so I want Josh to recount that anecdote for us, because I think it's a good way to set the table for the conversation.
Power buttons help. Hi, I'm Josh Corman. I'm the founder of IamTheCavalry.org. We're focused volunteer army of good guy hackers trying to focus on where bits and bytes meet flesh and blood, public safety, human life, Internet of Things. Jacki was privileged to serve on a congressional task force for healthcare cybersecurity. It was supposed to be 1 year long. It was supposed to be easy. It was supposed to focus on extending the fruits of HIPAA into the precision medicine expansion to make sure we had data privacy, et cetera. About 2 weeks before the task force met, Hollywood Presbyterian Hospital shut down patient care for a week and diverted ambulances to other facilities in LA traffic. So imagine being in an ambulance and bleeding, and you have to go somewhere else in LA traffic. And it really rocked me because I was working a lot on open source supply chain hygiene and known security flaws in open source libraries. And when you dug into that attack, the SamSam ransomware, it did not deliberately target that hospital. It just kind of happened. And it was due to a single Java flaw in a single Java library called JBoss and a single technology in the whole hospital. And yet that one little Achilles heel took out patient care. So I headed into that task force meeting and I said, I love my privacy. I'd like to be alive to enjoy it. And we're not gonna spend a year talking about patient records. We're gonna talk about pervasively trustworthy, available patient care delivery. So I asked the group, I said, is there any technical barrier to a sustained denial of patient care on any or all hospitals simultaneously? Because it's one thing to go up the street in LA traffic, it's another if every hospital in LA is shut down. And this is 1/6 of our economy. We all need it. We're born in a hospital. We go there when we're sick. We go there when we're hurt. We go there to die sometimes. It's very personal. It touches everybody. So we aged very quickly during that year. We said the healthcare task force was hazardous to our health. I think we all lost 5 years of life expectancy. I asked if we could have an amendment for free healthcare for life for ourselves. But if you fast forward, as we went through that traumatizing thing where to a person, everyone put in above and beyond the work because we cared so much about preventing that crisis of confidence. In fact, we defined a failure condition was not a loss of life. The failure condition was a crisis of confidence in the public to trust connected technology and anything that causes a retreat from otherwise superior life-saving advances. Because on the whole, these technologies are absolutely dropping the cost of care, increasing availability to care, all these things. So here's the personal bit. As we're trying to publish the task force report, in the midst of it, as we slouch towards Mother's Day weekend, our worst nightmare comes true. And the WannaCry attack takes out 81 hospitals in the UK in an afternoon. Now, they're not all hard shut down, but a significant portion of them are. Stroke and trauma centers are shut down. And when you have a stroke, you got the magic hours, like 3 hours to react, or it's gonna be permanent damage or death. And we knew people were dying. And we scurried and we tried to make sure the US wasn't affected, and the US got very, very lucky. But most of us didn't sleep that entire week. So on a Friday afternoon, it started, my deputy Bo Woods and I helped quarterback most of the US response. We did not sleep. I had to go to Europe and go to The Hague and help them Europeans prepare for their damage recovery. And I get back after most of that week, Thursday night, go to sleep for 3 hours. I wake up and I have to take my own 11-year-old daughter to the emergency room. She had something very wrong with her arms. It was affecting her fever. Turned out to be rhabdomyolysis. Didn't even know what the heck that thing was, but we couldn't get prompt care because all the systems were affected. And we're waiting in this little clinic for hours and hours and hours. My little girl's crying. And the part that I think Seth was hoping I would get to is 2 years prior to that, probably the proudest moment of the entire length of the cavalry is we had worked with empathy and an outstretched hand to convince the FDA to do the first corrective action in history on an FDA-approved medical device. It was a bedside infusion pump that had an unmitigated pathway to harm. It was unpackable, totally hackable, and you could give a full lethal dose of whatever drug was in the infusion pump. So proudest moment of my life, I cried when I told my kids that we stopped harm before any harm happened. And as I went to take her to the ER and had to go home to get her pajamas, after maybe 8 or 9 hours in the healthcare system, I came back and my little girl is hooked up to the very device, the only device that has ever to that moment received a medical safety communication saying this device is unsafe, hospitals should cease using it, and 2 years later it's hooked up to my little girl. And I just couldn't fathom like how intractable the problem looked, because the amount of work it took to convince the FDA that we have a problem, to convince them to use their regulatory authority, to start medical device makers on a path to making more safe and resilient and reliable devices. And even 2 years later, during the largest attack in history on hospital environments and clinical patient care, we're still using this stuff. We have this elective attack surface. And it's not to blame the hospitals, right? We're making the best decisions we have with the information we have. But the question becomes, will we get smart enough, fast enough? And the basic abstraction was that our overdependence on undependable things is creating these conditions where we're just kind of hoping that accidents and adversaries don't cause that crisis of confidence. And the rub for people like Jacki and I is we want to raise the alarm without being alarmist. Because if we're too intense, we can cause that crisis of confidence. But the failure condition we're experiencing now is we're not intense enough. So we're allowing people to continue to deploy unsafe technology or less safe technology. And we're playing with fire. So the question I'm going to have for you guys, even though we're going to have a robust discussion amongst the three of us, is what else can we try? And what's the best method to get through to the hospital administrators and the physicians? There's other anecdotes we'll get into for the pacemaker recalls that have happened since, but people don't yet believe that cyber hygiene is as important as washing your hands or scrubbing in before surgery. Like, we need to start to inculcate things that physicians and care deliverers already understand and care about, and make sure we have the commensurate care for this increased dependence on digital technology. So I don't know if that's a story you wanted, but it's, you know, it became incredibly personal for me at the end of a 1.5-year long marathon to see that no matter how much personal effort I had put into making sure my family's safe, we haven't finished, and we have a lot more to do.
Jacki, do you want to add anything to what Josh said, just because you were with him on the task force?
Yeah, I can echo, of course, his sentiments, but we do definitely have a long way to go. In fact, most of the recommendations from the task force haven't made a lot of progress, which obviously as task force members disappoints us because we put passion, blood and sweat into those recommendations on purpose, not to blame anybody, but really to get the industry to understand that we have to do something and we have to act now, because every day that we don't act, we put a patient's life at risk.
And I think that's a point that's not easily communicated, because the idea of scrubbing in is something that has been standard medicine for decades. And to now say that you also have to make sure that your devices have the latest security patches is hard to get around, because you don't want somebody who has a pacemaker to say, well, this needs a security update, and it doesn't have it, therefore it's unsafe to use. I mean, they need that pacemaker. How do you thread that needle in talking to the various stakeholders that you have to deal with? How do you communicate to them, this is important, but on the other hand, we'd rather you use the pacemaker than not?
Well, all of it is a patient safety issue at the end of the day, and I think that's how everybody needs to see it. People already understand that, you know, not washing your hands creates a safety issue. Where we aren't yet is the understanding that, you know, having an unpatched device, a pacemaker, implanted in a patient could also be a very significant patient safety issue. And that's the piece that I think we have a long way to go to get people to understand that. I think the other struggle that we have as healthcare systems that I can relate to Josh's story about why is my daughter hooked up to this 2 years after it was recalled. And honestly, it's because as a healthcare organization, we're constantly determining what is the highest risk and what do we invest our money in. And if somebody tells me that I have to go to my CEO and ask to replace all of our radiology imaging machines because they don't have good cyber hygiene, and they're $200,000 for each machine, there's no way that as a hospital system, and that's nonprofit, that we can afford to do that. So we're constantly trying to balance it. And I think the biggest struggle is that the technology evolved so quickly that it just didn't contemplate security at the time, and now it's more than caught up with us. And we're, in fact, encouraging interoperability, which is great for our patients in some respects, but it also scares me because it means there's more risk, more interconnectivity between these healthcare organizations that could potentially take down all of the US healthcare if something bad were to happen from a cyber standpoint.
To build on this, typically when we talk about the task force report, there were over 100 recommendations, and it wasn't meant to be a kitchen sink. We honestly tried to cut as many as we could, but we just saw that there were so many things to do for so many different stakeholders.
How many have been implemented?
Partially one.
The report came out when?
June of last year. So I do want to talk about that one, but not yet. But the thing that people did read was we made a graphic at the last minute. We said, no one's going to read this report, but maybe they'll read the graphic. So it's a thermometer, and it says healthcare cybersecurity is in critical condition. And I want you to watch your face when I say this. We had some very risk-averse people on the task force. And for them to unanimously agree to a title of healthcare cybersecurity is in critical condition, it tells you something. But the 5 bullets that we had for the 5 most uncomfortable truths were: number 1, dramatic workforce shortage. I forget what title we called it. But when we looked, there is not a census on how many security professionals are in healthcare, but our analysis based on the differences between large, medium, small, and rural, our estimate is 85% of the health delivery organizations in the US do not have a single security person on staff. Not one. Now, she has a large and robust team, probably not as large as she needs, but medium, small, and rural have basically 0. Number 2, legacy device problem. So it's not uncommon for Windows XP to be the best case operating system, which is so old, unsupported, and difficult to defend that even if you had a robust team, it would be much, much harder to do so. Not only is Windows XP end of life, Windows Vista, its successor, is end of life. And during the prep for this, we've learned that Windows 7, its successor, now requires additional maintenance for hospitals. You gotta pay more for older, harder stuff. Number 3, premature and hyperconnectivity, and this is the one the government doesn't like to hear, but HIPAA and meaningful use broke things. Because in our race to have hyperconnected devices, we tied reimbursement for medical technologies to the ability to receive and transmit electronic health records. Guess how many people redesign their products to safely receive and transmit health records? No, they slapped an internet interface on it. So that premature and hyperconnectivity made us connect things that were never meant to be connected to anything, forced to connect to everything. So we increased the blast radius such that a single flaw on a single device affects the entire health delivery organization. Number 4, flaws don't just affect privacy, they affect patient care delivery. And we saw that with Hollywood Presbyterian. And number 5, a known vulnerabilities epidemic. Now, not all of these are exploitable, but it was not uncommon for us to find a medical technology with over 1,000 known vulnerabilities or CVEs. Over 1,000. So I'm gonna put those together for you. By the way, it takes 1 to take out a hospital, as we saw with Hollywood Presbyterian and later with WannaCry. So let me put that together again. 85% of our hospitals don't have a single security person on staff. If they did, they're defending older and harder to defend things like Windows XP that are over-connected to each other and often reachable by the outside world, such that a single flaw on a single device can take out patient care for the entire unit, and the average device can give you over 1,000 chances to do so. One of them that Billy Rios inventoried had 1,446 vulnerabilities in it. So it's almost a miracle that we haven't had more WannaCries. And hope is not a strategy. So when we stitch those things together, it's stunning to me that only 1 of those task force recommendations has been acted upon. I'm really pleased with which one. I'm a little biased, but only 1.
Jacki, can you spend a bit of time talking about, from your perspective, what the challenges are in securing not just the devices that Josh has been talking about in these 1 vulnerabilities, but what I like to think of as the HVAC problem, where if you all remember the Target breach from a few years ago, they were breached from a third-party HVAC vendor. And we saw that earlier this year when Allscripts went down, which is a doctor transcription service.
Yeah, I can give you a specific example, and I can tell you that third-party risk management is one of my top issues. And the reason why it is because although Sutter might have good security, the vendors that we're connected with may not. So last year when we had the NotPetya issue with Nuance, in a day we had 1.8 million transcriptions in the queue, and we're evaluating how many surgeries needed to be canceled and what needed to be done to protect the safety of our patients. And that's just one example of one vendor. Almost every month I have an issue with a vendor who suffered a cyber attack. And the basic premise of why they've suffered a cyber attack is because they don't have good cybersecurity hygiene, even the basics. So they still think Norton antivirus is sufficient. And it doesn't matter how much due diligence we do as an organization and how much we bring it forward as a concern. or how much liability language we might have in those agreements. At the end of the day, that doesn't matter. The nuance one, we had a great agreement with them, but at the end of the day, I couldn't make us get transcriptions transcribed quicker to address our patient safety issue at that time.
How did you solve the nuance problem?
We hired lots of transcriptionists, a remote, to be able to do that. We were down for about 8 weeks with our core transcription service, and we ended up contracting with another vendor to address it. And honestly, we didn't have a good plan B. We came up with a plan B on the fly because we didn't have a choice. And I think that happens a lot, and obviously we have a significant amount of vendors, as most of healthcare does, and they have a wide variety. It can be a mom and pop shop to, the Google or Apple of the world. And so the level of sophistication from a cybersecurity standpoint is also large. So because we're so interconnected with them, I'm worried about our third parties every single day and worried about what we can do to address them. The other area that I'm really worried about is our physicians. In California, we're a corporate practice act, which means we can't employ our physicians. And so we have medical foundations, and we have lots of independent physicians who are affiliated with us. And so some of them might be a 2-doc practice, maybe a 10-doc practice. And they can't afford the same cybersecurity technology that Sutter Health can. And so we're grappling with, what do we do when we have a Stark law that makes us charge fair market value for those technologies that we deeply need them to have and want them to have? And I think there's a desire on their part too, but we can't take down their entire practice by making it focused on just investing in cybersecurity.
Yeah, one of the things that you pushed for pretty hard was there are already some softened exemptions to the Stark Law. Stark Law was a good idea, right? It was to prevent kickbacks, and so one of our recommendations was that, was there any pickup in Congress?
No progress on that. There's a couple of senators that were trying to push it through, and then CMS recently had a NPRM for Stark, which Sutter commented on, that we really want this Stark exception. There was a quick Stark exemption for meaningful use, as you might remember, a few years ago, where we could donate, big organizations could donate their electronic health record to physicians, which we did, but we still very much need that for cybersecurity.
I'd like to hear from both of you about which problems you feel are like the top 1 or 2 that should be dealt with as soon as possible.
I think my answer is changing over time. So the anti-answer is a lot of people rush to the medical devices, and the medical devices have been pretty terrible. But I actually have the most confidence of any topic on the trajectory of the medical devices. Suzanne Schwartz at FDA really had a wake-up call. Something flipped in her that made her realize the awesome responsibility that comes with fixing this. So she took pretty bold action on the pre-market guidance on the requirements to bring brand new medical devices to market. She completed and rounded that out with a post-market guidance on really bold things, including like strong incentives to have a coordinated vulnerability disclosure program, inviting researchers to report security issues to you. Like incredibly bold stuff for a federal regulatory agency. The issue with those is it just takes a long time. So if you and I were to start a medical device company today, and we have a concept, we architect it, we design it, we build it, we do pre-market trials, we go through pre-market approval, it's about 6 years. Implantable's even longer. So a lot of that reform has already happened, and a lot of medical devices are stepping up their game from not knowing to at least trying. But we won't see the fruits of that for most of those manufacturers for another 2 to 3 years. And that's just the trying stage. They're still making mistakes. So that one's at least on a trajectory. I think the areas that I'm most concerned about are the severe talent shortage, and there's no incentives to fix that. We spent months looking at creative solutions. In fact, some of our best ideas came after the report was published. But the second thing is the misaligned incentives for the hospitals. The number one thing we heard from the hospitals is there's just no money. We can't afford it. If we got any more money, we'd hire more nurses or buy more ambulances. And I have empathy for that. And flippantly, I got in trouble for saying this, I softened it, but I said, if you can't afford to protect it, you can't afford to connect it. Like, I might want to drive a tractor-trailer truck, but there's an awesome responsibility with driving a vehicle that large. I might want to fly a 747. I'm not allowed to. We have a surgeon shortage. I can't take a weekend crash course and be a heart surgeon. So there's some necessary competency required to be able to handle that awesome responsibility, and we haven't really factored that into healthcare. So after getting a huge fight with a friend who's a CISO in a southern hospital network, I softened it and I channeled my inner Stan Lee and I said, okay, fine, with great connectivity comes great responsibility. but it's no joke. I think everyone's so fatigued by JCO or by Joint Commission, sorry, or by other insurance things, and the cost of US-based medicine is so high and so broken. It's such a politicized topic as well. I feel that if we don't really work out the incentives, we're really not going to get any better. This won't be free, but there is a cost to connectivity. We've done the connectivity, we haven't paid the cost. And what people don't realize is, as intractable this is, and when you look at all the things that are just not negotiable, the fixed assumptions, you say, well, we can't change any of those. Well, if you can't change any of our fixed assumptions, we're toast. Straight up, we're toast. But we're gonna change those fixed assumptions. As soon as we have a mass casualty event, or as soon as we have that crisis of competence, we will make changes. They probably won't be good changes. So I feel like the biggest set of issues is a incentive and alignment set of issues. And the last mile has really been the physicians themselves. We haven't found the nut to crack that, or the finances and incentives around the hospitals. We got not precision medicine, we got meaningful use in electronic medical records by incentivizing it. We didn't measure it properly. We should have measured twice, cut once, but we could do an incentive hack again to right-size this and reveal the true costs.
Jacki, as a hospital representative, I'd like to hear what you feel Sutter Health could be doing along the lines of what Josh was recommending.
So I view our role as a big organization that does have resources. You know, I don't have endless resources. I don't get everything that I want, but I feel pretty lucky that I have leadership who understand the problem and are supporting me in everything that my team needs. You know, I think our role is to help articulate the problem as we are right now, and to help with resources as much as we can. Unfortunately, with the regulatory barriers, it actually doesn't help us assist both our vendors and our physicians as much as we'd want to. And as Josh articulated, our biggest issue is resources, because nonprofit healthcare does not have we have to make tough decisions every day about what we want to spend money on and how we spend money. And you know, having basic cyber hygiene just isn't something that's realistic for every single healthcare organization without them having to close their doors. And although we don't want to ever get to that point, we have to get to a point where they're resourced enough that they have basic cyber hygiene.
A lot of this is education as well. So we did the first ever clinical hacking simulations in Phoenix, Arizona last June as well. We did it with 2 physicians who happened to also be hackers. So we did the perfect merger of the art of the possible for hacking with 3 demonstrable hacks on the actual interface with human physiology. And all 3 guinea pigs in the medical device simulations, their patients coded, some plural times. None of them knew it was a compromised device. Not one asked for an autopsy or a forensics investigation after. So it was a really humbling experience. But in the course of doing that, they said, well, we don't have any money to buy new bedside infusion pumps. And I said, well, you're going to buy some new ones anyway, right? I said, well, yeah, but we don't buy them all at once. I said, well, what's your next batch? They go, we're gonna buy 20% of the new ones. I said, okay, so don't spend more money. Spend your money better. And one of the things the cavalry put out early was called the Hippocratic Oath for connected medical devices. And it was basically 5 things to ask your medical device manufacturer. Like, basically, we talked about failure conditions. Said, how do you avoid failure? Take help avoiding failure without suing the helper. Capture, study, and learn from failure, inoculate against future failure, and contain and isolate failure. And there's a bunch of really clever words in there that sound like the Hippocratic Oath, so it sounds very familiar. But, you know, when they go to buy the next bedside infusion pump, is it patchable? Do they have a disclosure program inviting hackers to tell them of issues before bad guys do? You know, do they have evidence capture and logging to meaningfully contribute to an autopsy or a forensics investigation? So it doesn't cost more for that other device. It's just you're aiming your future renewal dollars at the right kinds of things. So sometimes I think the issue is an education or an attitude one. It isn't spend more, it's spend better. Or it's be a more informed consumer. Or maybe you didn't think we should invest in segmenting and isolating parts of the network, but maybe a few security people can take really vulnerable devices and shield them from the outside world and all internet noise. So it doesn't have to be expensive. We just have to internalize these new realities.
But you're also assuming that those hospitals have the cybersecurity resources to understand what those med devices need. And that, I think, is a huge challenge. We just don't have that level of talent across there. I field phone calls. I never turn down a phone call from a smaller organization, from anybody who wants to talk to my team about what they should do from a strategy standpoint, because they need that help. And most of them are small CIOs. They could be director of operations from a small system who's trying to figure out what to do and how to tackle it. And it's just a huge challenge because we have a huge shortage of it, and they can't afford it. You know, even you know, we're lucky to be in Northern California, but I'm competing with the tech companies in Silicon Valley for my talent. And so that is a challenge too, because I can't compete with the salaries that they can offer in Silicon Valley. So it's even a real thing for big healthcare organizations to get that same cybersecurity talent that we need.
I mean, it sounds like we're facing a phenomenal level of problems. How did we get here? I mean, is this because of laws like HIPAA? You know, what brought us to this point where things are happening in such a counterintuitive way that you want to do education, but you can't afford it? You want to get new devices, but you can't afford them. You need to hire new people, but they don't exist.
Dr. Kevin Fu was one of the first to do a medical device hack. I asked him about this before I even started the Cavalry. I said, am I just doing a fool's errand? He said, well, Semmelweis, it took 100 years for people to listen to him. You know, it's going to take 100 years before we get better here. I said, I can't wait that long. And we can't wait that long because we're going to have that crisis of confidence. But his line, I will never forget it. He said, Josh, I said, why the heck would anybody put Bluetooth on an insulin pump? It's on your hip. You can touch the buttons. Like, why the heck would anyone do that? And his answer was, it's the bacon principle. Everything's better with bacon. Everything's better with Bluetooth. And we just never really articulated the risk of doing so. Now, some of those remote access technologies are important, maybe even necessary, and if they're done safely, it's a good thing. But we just like any technology, humans adopt technology for their immediate and obvious benefits, and they never do the cost-benefit analysis for the less obvious delayed consequences. The second one, though, which I already mentioned in the thermometer slide, I really think the thing that weaponized the problem was meaningful use, tying reimbursement to the ability to receive and transmit electronic health records before ready.
So this is a federal legal problem.
The road to hell is paved with good intentions, but that particular move, and I think we pretty much had a near unanimous consensus that I asked it as a question instead of a threat. I said, is meaningful use our original sin? And there were crickets.
Actually, can you guys take a moment and actually define what meaningful use is for people who may not know?
If you want money, you have to be able to receive and transmit electronic health records.
Yeah, so it's essentially an incentive for healthcare organizations to adopt electronic health record, and in doing so, they got paid certain incentives based on how they did it, and the incentives are still being paid out today. I think they're paid out through 2020, and it's a significant amount of money to support the technology for basically interoperability and electronic health record, which there's also a lot of benefits to it. I know we're talking about the negatives related to security, but there's a ton of benefits, and I think meaningful use started it because everybody started adopting it and they realized how beneficial it was to patients, and it's just continued to grow. I mean, now we're talking about interoperability. There's an ONC group who's working on that. That's really pushing health information exchanges and connecting hospitals, and that is great for a patient who's seen or shows up at an ED in a Florida hospital and is a California patient. That's awesome, but with it creates security issues for us because the technology didn't contemplate security.
I mean, this is a terrible metaphor, but I need a better one, so I'm going to keep saying the bad one until someone replaces it. If we said, look, sea levels are rising and all cars need to be aquatic vehicles, like all cars need to be able to drive in water, right? you would take all the current cars on the road and you put duct tape and caulking and stuff the ventilation, and you'd try to make a car that could maybe survive in water. But what you'd rather do is design a car that was meant to be in the water often and for long periods of time. You would design the car differently. And I think what we did is we just kind of took the existing cars and we made them hyper-connected. And that's why I'm so hard on it. It's not that it was a bad thing. We've saved tons of money. We've improved things. Like illegible doctor's notes, wasn't a good thing. But we didn't really gather all the system requirements.
And there's a negative incentive as well, right? Doctors are penalized if they don't adopt EHRs.
Absolutely.
So.
What's the new one called? It's not called meaningful use anymore.
I don't know.
All right. So one of the interesting things in the struggle for other industries to solve getting devices updated and getting their vendors to take vulnerabilities seriously has been a Google team called Project Zero. Sorry. Yeah. And for those who don't know, Project Zero is a team within Google where they find vulnerabilities and they notify the vendors. They give them a window to update them, and then if they don't update or create a patch for those vulnerabilities in enough time, they release the vulnerability to the public, which is called a 0-day, hence Project Zero. And I'd really like to hear from both of you what Project Zero for medical devices and even medical organizations would mean, and is there a window that would be acceptable? Maybe not the 90 days of Google's Project Zero, but maybe 180 or 360 or something.
Mayo did something similar. They actually invited device manufacturers to their facility, had hackers, published a 1,100, I think, page report on all the vulnerabilities with medical devices, and we haven't seen much movement with it. So I think it works in other industries, but so far we haven't seen it work here. Maybe on new devices, we're starting to see that they're incorporating things, but definitely we get into this fight, as I mentioned before, about hospitals just need to replace all their medical devices, and that's not realistic. There's of course other things that we can do, but I'm not sure if that would work in healthcare.
So I'll give the FDA answer, and a lot of the hackers helped craft the FDA answer. And I am not the FDA, so I shouldn't speak for them, but I'll describe in my own layman's terms what they did. With the post-market guidance draft, which is basically the ongoing care and feeding expectations once you've already brought a medical device to market, I'm going to use my language. They basically said, if you have a coordinated vulnerability disclosure program inviting researchers to act in good faith to report issues to you, and you can fix the issue reported to you within 30 days, then we won't get involved with the regulatory action. Now, there's all sorts of other caveats, like it has to be a controlled vulnerability versus uncontrolled vulnerability. But it's basically a carrot-shaped stick. If you invite hackers, and you can have a prompt and agile response, we will not use the heavy hand of regulatory action. And they all freaked out. They're like, 30 days? Are you kidding me? It takes 180 days to do our QA or quality assurance cycle. There's no way we could do that. And some point between the draft guidance in January and the final guidance in December, they said, okay, fine. If you can mitigate it in 30 days and fix it in 60 days, then you get the incentive. If you don't, it's okay. We'll just do a recall. You know what happened? A bunch of the big tier medical device manufacturers said, what kind of changes do we have to make to our design and software development lifecycle to actually hit 30 or 60 days? And one of them started doing DevOps, like California, Silicon Valley, CI/CD, and they got their QA process down to 15 days. You have an FDA-approved medical device manufacturer who can respond to a new vulnerability in 15 to 30 days. Now, sometimes necessity is the mother of invention. So is it a Project Zero? No. Am I terrified at the idea of a hard limit on a public disclosure for medical devices? Absolutely. I really hope that kind of thing doesn't happen. But the FDA intermediate take for safety critical devices is they're highly encouraging that. In fact, Chairman Gottlieb asked Congress for authority to require coordinated disclosure program for medical device vendors. So boiling the frog, they went from nothing to a spiff or incentive to now maybe a hard requirement.
Any thoughts on it, Jacki?
I'll believe it when I see it.
Question from the internet here. What kinds of mass casualties do you foresee happening because of the connection without protection problem? And what's going to wake up decision makers about investing adequately in security, or wake up policymakers for that matter?
So I don't think every device type is the mass casualty type. Also, let me state this because we haven't stated it yet. People keep saying, "Oh, no one would ever do that." Bo Woods has a fantastic line. Malicious intent is not a prerequisite to harm. The WannaCry attacks did not target hospitals. They just asymmetrically hit hospitals because hospitals have terrible gateway hygiene. SamSam did not target Hollywood Presbyterian. It just hit it because the internet noise is enough to do harm. So I think the really acute problems will be on things that touch humans, like bedside infusion pumps. The one that scares me the most, the one that scared everyone on television from our clinical hacking was the one at Nightline, NBC Nightline, ABC Nightline, was the pacemaker defibrillator that we gave an electroshock to the patient every minute on the minute, and it caused a cardiac arrest every so often. That scared people. The one that scared me was the bedside infusion pump. They're in every single hospital room. In NICU, you might have 8 hooked up to the kid at the same time. That's the one that scares me, right? Not just that, but there's a subset of devices that I think would happen. So I think the mass casualty event comes from either denial of patient care for the whole facility, like we did tabletop exercises on, taking out the HVAC, no air conditioning in Arizona, things get hot real fast. We shut down the elevators, you can't get patients to the surgical floors. So just those 2 things with default passwords was enough to do one of those mass casualty or crisis of confidence events. So I think you don't look at all the things that could go wrong, you look at the specific narrow cases where the cost of failure is unacceptable, and that's where we marshal our limited resources.
And I think we have to drill. We drill, we talk about what could potentially happen and plan for the possibility of it happening. And that also helps us see what we're missing. Would anybody have anticipated the HVAC being an issue prior to it happening? I'm not sure. I'm not sure if they would, so it's important to be able to evaluate and think about what actually could create this kind of impact and what can we do about it. With biomed devices, we can segment them on a different network, and that might solve some of the problem. Certainly not going to solve it when it's implanted in a patient, but it's going to solve some of our problems. So those are the types of things, I call that risk analysis, risk management, that we have to do too, because we don't have endless dollars.
I'm going to say things that contradict each other. We had the first actual recall was the St. Jude Medical pacemaker recall after the MedSec muddy water stock short. So those bugs did exist. Firmware updates were provided. There were about 750,000 patients that could or should have taken a firmware update. Very few physicians have applied the update. And some of the assumptions that went into their decision not to even tell their patients about it are being scrutinized, and they're based on incomplete information. I don't think the mass casualty event will be that. One of the first things that Christian Meth told us when we did this thing is you don't have to hack someone's pacemaker. For 94% of them, they just get tired. Like, it's not a Homeland movie or TV show. They get tired. A very, very small percentage of the population that needs a pacemaker actually needs every beat of their heart. It's usually just for error boundaries. And they go to their doctor and they get it tweaked. So he said, stop talking about hacking people's pacemakers. Now then he showed us how to hack someone's pacemaker and actually kill them, so he did refine our aim, but we have to talk about the right problems. Now that said, if you go the other direction, if we're cavalier about these highly avoidable things, one thing physicians don't understand is most medical device failures admit to a Bayesian bell curve. Like, a couple of them start to break down, you notice a trend, you have error reporting through mod databases, and then you might do something about it. The physics of cybersecurity is you go from no exploitation to 100% exploitation in moments. So our basic assumptions about how failure conditions manifest don't apply. And we haven't really inculcated the demographic with that. It's a very all or nothing kind of proposition for these. So while I don't think you're gonna see a mass exploitation of pacemakers, when someone does it, it would happen fast.
Jacki, earlier you spoke about how you're always willing to take calls from other healthcare organizations, hospitals. Does Sutter Health or other similarly sized organizations, do they reach out and put out guidance as to what they're doing and how you guys think that other medical groups should be responding to cybersecurity issues?
No, not to the degree that we probably should, because it's a bandwidth issue. You know, we're happy to talk. When we had NotPetya, WannaCry, you know, many of my team members were participating in many phone calls at the government level and with other healthcare organizations, giving them suggestions on how to remediate and handle things. But in general, we don't put things like that in writing and send out the guidance. Ideally, that'd be great if we had the resources to do it.
So then how are organizations supposed to get past this 85% problem where they don't have an expert on hand, there's no one in the area?
They're not going to without our help.
We spend an awful lot of time on the strategic workforce gap, and we could not come up with a single good idea. We had a lot of little ideas. We found a group in Illinois. They pooled resources, started a nonprofit, and they hired a CISO to share. We looked at that model and the benefits of it, but a single CISO for 20 HDOs wasn't really going to work. I mean, how many people do you have in your team? More than, measured in tens at least?
Yeah.
A single person's not going to work, but it was an interesting concept. We looked at like scholarship for service, where if you serve in the U.S. government, you get your college paid for. We said, could we extend that to parts of designated critical infrastructure like healthcare? We looked at Jim Routh, who runs the National Healthcare ISAC and is also part of the Financial Services ISAC. He asked CISOs retiring from banks, can you please do a 2-year tour of duty to train someone before you completely retire? It's a nice idea. Doesn't scale super fast. Sadly, after the task force report was published, our 2 best ideas emerged. I guess there's these geographically dispersed, federally subsidized 50-bed hospital types. I can't remember what they're called. We already know where they are, so you don't have a food desert from no grocery stores. These are basically, so you don't have a trauma desert for no beds or for no urgent care facilities, I think it was called. We said, what if we were to subsidize or scholarship a CISO per one of those, because we already know where to put them and how many there are. We can budget for that. But one of the best ideas was the hardest thing is to get a metropolitan California or New York City-based CISO to want to move to Wichita or Panhandle, Florida. So the real issue was the rural, and what we said is, who wants to be in rural? Oh, veterans who come home and don't have a job. Like, could we do a work program to train and place cybersecurity skills into rural America so they can go back to their own community and serve in a different way? A lot of them are already protectors by their nature. So none of them are fantastic ideas, but that can allow someone like Jacki with a large team and resources to at least coach and Sherpa. But just like Google has flex time, we also had this notion of tech talent getting time or permission to mentor or advise without liability, of course, but advise their local clinical environment.
I think I think obviously there's not a perfect solution for it, and even with Josh's solutions, I'm a lawyer by trade, so I like to poke holes in everything, is, you know, even a CISO is not going to probably have all the skills that we need to carry through security, for example. You know, I can tell you my technical analysts are way more technical than I am. Can I understand it? Of course, but if I was responsible for, you know, 10 hospitals to do everything from start to finish, I couldn't do it.
Well, what do you think is going to happen when we do have a crisis of competence? We will respond. We'll make adjustments. They'll be costly. They may be malformed, but we will make some sort of response.
We always do.
Yeah.
One question we've had from the audience actually is what role artificial intelligence can play in solving any of these problems. It's very buzzy, but it's also a legitimate question.
I just thought of the solution to everything. We should just make a medical blockchain. Right.
made some people here very happy with that.
I thought you were going to say cloning.
Oh, no, even better. We
Cloning.
could do a next-gen quantum blockchain.
There you go.
As a service, with crowdsourced intelligence in the deep, deep dark web. Well, we did talk about technology innovation because we wanted to go to the venture capitalists, and we said, you know, there's a lot of solvable problems here. If you look at the $80 billion of cybersecurity kit or products and services, a lot of them make a heavy assumption that there's a human talent pool to deploy and operate them. And what we started asking is, how would you design the minimum number of technology boxes in a hospital to do the maximum good? And we kind of want to turn this into a grand challenge because I don't know how many technologists are in the room, so I'll say this quickly. If you could do something that monitored, one of the reasons they don't segment in the hospitals is they don't know what systems might need to talk to another system. So they just leave everything wide open, flat. What if you could watch the network for a period of time with like a free net flow analysis thing like Cactus or something, and then calcify those conversations so that you've observed need to know, and then just enforce those need to know cohorts. And yes, there's a change management burden, but that's a very low human cost for possibly higher things. And when we went to the VC-based innovators, they're like, yeah, we thought about doing that, but there's no money and there's no buyer. And then we went to the VCs and we're like, oh yeah, but the money we want to spend in healthcare is really on informatics or on telemedicine. And like, the hospitals don't think cybersecurity is an issue. So I think there's some real nice technology innovations for watching and learning and adapting, or at least hinting at change management. And I'd really like to stimulate and catalyze that. One of the reasons we talk to technology innovators in things like this is maybe one of these audience members is gonna have a really cool idea and say, yeah, I'm gonna go do that. I don't think it's gonna solve everything, but the WannaCry thing was basically just keeping something open to the naked internet that never should have been open. That was an entirely avoidable problem. That was a preventable set of harm. And I'm hoping things like watching and hardening need-to-know cohorts of devices in a facility might help there. So there's a role for it. We just need someone who wants to try it.
And I think artificial intelligence has to play a role. I think that's the only way we're going to get to a point. If we rely on human intervention, we'll never get there.
So what does that look like? What does an AI helper look like? Quinn wants to ask a question.
I think she has the answer.
She may have the answer.
You have the answer?
Mm.
Can they hear? Basically, I think Quinn's asserting that even hand washing is not fully settled. And no. Here's what I took from it, whether you meant this or not, I'll watch your face. We did talk about that a lot, it's not just incentives, but a lot of this is also like just understanding human behavior and behavioral modifications and using the right language. One of the reasons the Hippocratic Oath for connected medical devices was so powerful is that we used incredibly familiar language that's already native to the zeitgeist of care providers. Like, they already have a lot of that baked into what drew them to the profession, and using familiar language made it more accessible. We actually work with a nurse out of Poland, Yelena, and she's very aggressive in her language, but she basically says, slightly differently than I do, she says, you would never do surgery without sterile equipment. Why would you do surgery with unsterile software? When we were in the task force, the horror stories I heard, a cath lab had a guided wire in a heart, keeping the flutter open. It rebooted during the procedure. 12 minutes of waiting, hoping, 12 minutes of waiting and hoping that that thing would recover and be usable within the body.
And that was just, that, I'd like to tell you that was the only story we got. And these are from people in the clinical environment. So those types of things, when we use the hygiene and sterile equipment language, it resonated more than when we said, ooh, spooky cybersecurity stuff. Feedback loops, yeah. Okay.
Yeah. Sorry.
The famous example of this is the hospital that actually introduced a very low-tech approach. They set up a video camera at the exit to the ICU. Anybody that left would be on a video camera, which was focused in on the large ID badges that they had. It was connected to a call center immediately. If you didn't wash your hands at the sink that was right there, you got a call.
Which actually leads me on to my second question, which is how much did you look at the possibility of using remote teams to augment security infrastructure as well as more intrusive?
I'd like to hear Jacki answer that one.
So we discussed it a bit, and I actually think it does exist. I know of a few organizations like Intermountain who's doing that already and supporting other organizations. So it's making some headway, but we're not all the way there because you've got to get people to buy into it.
We did a huge analysis of managed security services, outsourcing. We talked to some of the largest providers and we said, could you do, even if the government subsidized it, could you do a discounted program for the impoverished units? And there was some interesting exploration there. The key bottleneck we found is they're really an assist function. They can't replace, I think the phrase we use is you need a lead actor before you have the supporting actor. So that's why we started focusing on at least one qualified security professional per HDO. We didn't want one, by the way. Our minimum viable team was 5 with different roles, and it still isn't good enough to have 5, but we had such huge fights over even asking for 1. But there is definitely a role for the remote assist, but it can't be a remote replace.
Yeah, but I kind of disagree with that a bit because EICU, think about that. Physicians see patients from afar, and there might just be a nurse in the room. I think it's a possibility if you have the right talent on the team. They don't necessarily have to be security talent. If they're remoting in and assisting them from afar, I think it could actually work.
Question in the back, Michael.
Jacki, you mentioned liability clauses in contracts. What role do you think liability could potentially play in this situation?
Nothing. So the question was, what role can liability language play? I think the challenge is you end up getting into lawsuits that, as a lawyer, they end up lasting 10 years, and it's too late by then to actually address it. So I haven't seen, we have almost complete indemnification in all of our agreements. We work really hard to get that. And one, we haven't sued any of these vendors who have actually had cyber attacks that have impacted our patients and our employee data because of the litigation and the cost of that. And then I think the other piece is people could potentially go out of business, and it might be an important life-saving thing that vendor is providing. So I don't think it's that helpful. It's used as sort of what I would call the big stick, but the big stick doesn't actually work to get people to do things. I can't get some vendors to even think that multi-factor authentication is a thing. They think I'm crazy, and that might be as simple as it is, basic cyber hygiene. And so I would much rather have actual basic cyber hygiene and less of a stick on liability language than anything else, because that's actually going to mitigate the risk.
Without a fight about it, there's many types of liability, and one of the law professors that's been going to DEF CON one of the longest amount of times, Andrea Matwishin, she's got the first legal brief on the subject going through review right now. It's called the Internet of Bodies, and it means more things than just the fact that we're going to have dead bodies from hacking. It's a whole bunch of other privacy and ownership type things with augmented self, and it's trying to ask the questions before we have to answer them. But there are types of liability and limited liability for the devices. There's also insurance and insurability of hospitals, and there's other market levers. Right now, many of them aren't being touched. So, you know, what we did a talk a couple years back at RSA on software liability. We call it the worst possible idea, except for all others. And you got to put the uncomfortable stuff on the table, even if it's super uncomfortable.
We're going to do two more questions. Chinsi, you had a question?
Yeah, so I thought that the analogy breaks down in the sense that even if we can solve the incentive problem, get people all to wash hands, right? So at least people know how to wash hands, okay? It's not, doesn't require an expert to wash hands. The cybersecurity one is not the same. Even if you have the incentives, hospitals have to hire experts to scan your code, to look at your device. It's not as easy. It's not like hiring someone out of medical school, right? So the problem has to be fixed upstream.
Yeah, most of the point being, like, you can't just wash your hands and be immune to cyber attacks, especially with determined adversaries. Most of the focus we aimed at was for the accidents and low-skill adversaries. There's lots of reasons why. I could show you a beautiful graphic. Yeah. Accidents and adversaries.
It's the low sort of caliber, software.
Right.
Flaws that should be fixed
Yeah.
before you even get to hospitals.
So
Why put the burden on hospitals?
we don't want to put the burden on hospitals. I completely agree. And that's why most of the work was on upstream medical device hygiene, better devices to begin with, more maintainable devices. Because we know that the economics of the hospital won't get better, maybe ever. They might get slightly better, but in the enterprise, we shift the burden to buying blinky boxes, desktop agents, and high-paid talent. If you know you'll never get the high-paid talent for a number of reasons, you shift the design principles towards the hygiene and the maintainability and complexity reduction of those devices. So we did not assume it would be take everything from enterprise security and port it to medical. That's not the right answer. But there's still, the shared responsibility shifts the focus, but it doesn't eliminate the physics.
Last question for someone who hasn't asked one. Yes?
Hi, both of you mentioned a bit about the responsibility of the device makers, which you both also allude to supply chain security. And you said earlier in the talk that the advice would be to buy smarter, not spend more. So for organizations, they don't have AppSec engineers, they don't have red teamers, they don't have people who can evaluate devices. What would be the advice for those organizations on how to spend in a smarter way? Not increase their budget, but funnel that money towards more secure devices. What are their options?
Well, the FDA is making the whole supply chain generally better, slowly. The easiest, most human understandable language is that Hippocratic Oath. It's the 5 things. It's a fairly abstracted, oversimplified checklist of things to look for that a lot of medical device makers aren't doing yet. So that's probably the most simplified, tweetable answer is the Hippocratic Oath. It's at imthecavalry.org/oath. Really hard to remember. It's being used by procurement language at Mayo Clinic and elsewhere, and it's actually, if you squint, the UL Underwriters Laboratories is becoming another market signal, which is they have the Cyber Assurance Program, or CAP. And there's a few medical devices that have gone through it. They want to see, do you have a software bill of materials? Are there any known vulnerabilities in it? Are you patchable? Have you gone through static and dynamic analysis and pen testing? And if you do these things and you create a document, you can get this assurance. Now, is it perfect saying it's unhackable? Heck no. But if that starts to become a procurement abstraction, like you and I might drive a 4 or a 5-star rated car, you might not know everything that goes into the stars, but if you just had a new kid and you want a safer car, you're gonna go out and buy a 5 instead of a 4. So market signals and abstractions can be helpful here, and there's starting to be a few of them. But right now, the most readily available one is probably the 5-star. I mean, the Hippocratic Oath.
Jacki, last word?
Nothing to add to that.
We're over time, so thank you all very much for listening to us. I'd like us to think of this as the beginning of the conversation, not the end of it, because this is not something that's going to go away anytime soon. Yes, Josh, last thought.
We hinted at the only bright spot from the task force report. There's one task force report item that's being acted
Yes,
on.
and you never said what it was.
So what it is We said, and it was right from that original thing about Hollywood Presbyterian, they were warned by the FBI and InfraGard, if you have JBoss blah, dot, blah, dot, blah, you might be affected. No one could tell if they had JBoss blah, dot, blah, dot, blah. So I called for, strenuously, a software bill of materials for all medical technologies. House Energy and Commerce, which has oversight over HHS, said, we love this. And right around Thanksgiving, he said, go do it. So HHS now has authority and is implementing a software bill of materials and ingredients list of all the third-party and open source libraries. That way, if there's an attack on the news saying it's affecting project X.Y.Z, hospitals can quickly tell which systems might be affected. That one's happening.
Thank you, everybody. And thank you, Josh and Jacki, for your time. Really appreciate it. Josh for coming out from a very long distance, Jacki from a slightly shorter distance. Right, the traffic was bad. And I think Chen Si, who represents one of our sponsors, has a quick closing statement for us.
Thank you. Thank you all for coming. I really enjoyed today's conversation. I just want to say that we're going to be doing our next one at the end of October, and the subject matter is going to be election security. So I hope all of you will be here, and bring your friends, bring your colleagues. Hopefully we'll have a great conversation just like tonight. Thank you.